In this capture, we're going to take a look at anemias and treatment-related procedures. So let's start with some terminology. An erythrocyte is a red blood cell. Going down a little bit further, a reticulocyte is considered an immature red blood cell that's released based on demand. So if you kind of think about a bleeding situation in your body, okay, if your body's lost a certain amount of blood, your body recognizes that and it's going to stimulate the production of red blood cells. And because you need them right now, it's going to release them as immature instead of waiting for them to be fully mature. A thrombocyte is a platelet. A leukocyte is a white blood cell. And within the leukocytes, a neutrophil is a subtype of a white blood cell. A mature neutrophil has a segmented nucleus, so it's often called a seg. An immature neutrophil is single-lobed, and it's often called a band. And the reason I mention those terms is because you'll see a lot, especially in the clinical setting, where a patient has an acute bacterial infection, and when you look at their differential, their white blood cell count with the differential, you'll see an increase in the neutrophils, and if they break it down, you're going to see an increase in production of band neutrophils, immature neutrophils, to fight the infection. And you'll often hear this term called a shift to the left. So looking at hematologic studies, let's start with the complete blood count. In a CBC, we're mainly looking at the red blood cells, the hemoglobin, hematocrit, white blood cells, and platelets. It does also give some red blood cell indices, and we'll talk about those in a little bit. Okay, a CBC with a differential has everything that we just talked about along with the white blood cell subtypes. The other main hematological study we'll look at is a peripheral blood smear. So this is where they literally take a sample of blood, they put it on a microscope, and they look at it. And they're looking at the cell shape and the appearance of the actual cells. So it's manual, it's an actual microscopic exam of blood on a slide. Some of you may have done this as part of anatomy and physiology or perhaps even microbiology. So looking at the hematological studies, let's kind of drill down a little bit here. The red blood cells, that number that you get on there is the number of circulating red blood cells in a microliter. Okay, so for females, a normal range is 4.2 to 5.4 million per microliter. And males are 4.7 to 6.1 million RBCs per microliter. Okay, if those numbers are decreased, the patient is considered to have anemia. They are anemic. Okay, red blood cells have a maximum of 120-day lifespan, keeping in mind that that lifespan can be shorter if the blood cell is abnormal, external trauma, internal trauma like from mechanical valves or buildup of plaque on the vessel walls. Those things are going to shorten the lifespan. Now, hemoglobin is the total amount of hemoglobin in the peripheral blood. Okay, so hemoglobin is the oxygen carrying molecule of the red blood cell. So it's all about facilitating oxygen transport. So it makes sense if I have fewer red blood cells, my hemoglobin is also going to be down. So in many cases, not all cases, but in many cases, when you see a decreased red blood cell, you will also see a decreased hemoglobin. So normal hemoglobin levels for females are 12 to 16 grams per deciliter. For males, it's 14 to 18 grams per deciliter. Now, hematocrit, if you remember from foundations when we talk about fluid balance, hematocrit is the percent of total blood volume that's made up of RBCs. So if you take a look at the picture that's on the screen, and you'll see a vial of blood that has been spun down. And you see on the very bottom, there's the red cells. There's kind of a little line that's a little bit lighter. That's kind of your white blood cells and platelets. And the rest of it is going to be your plasma. So it looks at the percentage of the total blood volume that's made up of the RBCs. Generally, as a rule of thumb, it's going to be 3 times the hemoglobin concentration. Okay, so for females, normal is considered 37 to 47%, males 42 to 52%. Now remember, hematocrit is going to be altered by how hydrated your patient is. If they are fluid volume overloaded, their hematocrit is going to look decreased. If they are dry, if they are dehydrated, fluid volume deficit, that hemoglobin or that hematocrit is going to look elevated. Looking at the leukocytes or the white blood cells, these are a key aspect of the immune system. Okay, so kind of think white blood cells, immunity. So your normal total count is generally going to be 4 to 11,000 cells per cubic millimeter. So increases in white cells are related to infection, inflammation, and neoplasia, which refers to a cancer or leukemia type condition. Decreased white blood cells indicate immune suppression, so your patient is at higher risk for contracting an infection. Now the differential is going to show the percentage of each subtype, and I have those listed over on the screen. So neutrophils, lymphocytes, monocytes, eosinophils, and basophils. Never let monkeys eat bananas. Okay, that's how you remember that. Right now, we're not going to go into all of those, but I want you to kind of understand the neutrophils. So they are the most prolific white blood cell type. 55 to 70% is typically your normal percentage. Those will increase in acute bacterial infections. Okay, now I do want you to understand that those are based on percentages. So if the neutrophils go up, something else is going to decrease to make up the balance of that. Okay, because those are all out of the total pie of 100%. So just understand, if you're at clinical and you're looking at, your patient's blood cells, okay, on their CBC, if their neutrophils are really high, it's not uncommon to see something else that might be a little bit lower because of it balancing out. Looking at thrombocytes or platelets, the normal count is 150 to 400,000 cells per cubic millimeter. Counts under 100,000 indicate thrombocytopenia, so low platelets. That can lead to spontaneous hemorrhage. It can lead to petechiae, the little kind of pinpoint red bruising dots all over the body, or ecchymosis, which are larger areas of bruising. Causes are essentially just reduced production of platelets in the bone marrow or increased destruction of platelets, which can happen from trauma. It can happen from certain medications as well. Counts above 400,000 indicate what we call thrombocytosis. And the problem is, if you have too many platelets, especially if your patient's not very hydrated, they're closer together, they're more likely to stick together and form a clot that can then become lodged in tissues and actually cut off blood supply to areas of the body. Most likely it is associated with malignancy. Usually it's a leukemia, lymphoma, solid tumor if it's elevated. But you need to keep in mind that just because your patient has elevated platelets doesn't mean that they're not at risk for bleeding, because they might have the platelets, but remember, the platelets have to actually be activated to form a clot. So just because they have a lot of them, if they're not working properly, they could still potentially be at risk for bleeding. They're actually at risk for both. So a bone marrow aspiration with biopsy. This is a procedure where they're actually harvesting, not really harvesting, they're getting a sample of the bone marrow. It's kind of the same procedure they use for bone marrow harvesting, but they just do it on a more expanded scale. But basically, they're going to use a special instrument to go into the bone. Usually we're talking about the pelvic bones, going in there and actually digging around in there and aspirating out a sample of bone marrow. This is a pretty invasive procedure. It requires assigned consent. Patient is positioned prone or side lying. Typically, they're going to use a local anesthetic, okay, and maybe a little bit of sedation, but they are not out. Okay, they are not out. That aspiration, when they suck out that bone marrow, it's going to cause sharp pain and pressure. So if they're just having a bone marrow aspiration with biopsy, it's usually a single site that they're taking it from. If they are donating their bone marrow, they're a bone marrow donor, they're going to do that from multiple sites. Usually, if they're a bone marrow donor and they're doing it from multiple sites, they're going to have them pretty significantly sedated, maybe even general anesthesia. But for a simple aspiration with biopsy, it's going to be a local anesthetic only. As a nurse, there's going to be a sterile dressing placed over that aspiration biopsy site. You want to maintain that dressing, sterile technique, and you want to observe for any signs of bleeding. If so, you would want to reinforce the dressing and hold pressure, notify the provider, and of course, they're always at risk for infection, so we want to keep an eye on that. Our other big thing is going to be post-procedure pain management. Again, they'll often use things such as acetaminophen, kind of around-the-clock dosing, and then they'll use something like an opioid and oxycodone for breakthrough pain. But it should be relatively short-lived. They should not be on those for a long period of time. So, kind of getting into the anemias, now that we kind of looked at some background, we need to talk a little bit about red blood cell development, because anemia by definition is decreased red blood cells, decreased hemoglobin, decreased hematocrit. So red blood cells begin to develop in the bone marrow, okay? They actually mature in the blood. So for this whole process to happen, there's a couple things that you need to have. You need to have healthy bone marrow. So somebody with leukemia, lymphoma does not have healthy bone marrow. You need erythropoietin, which is a hormone that is produced by the kidneys. Yeah, I bet you didn't see that one coming. Now, the kidneys do a lot more than just make urine. So one of the things they do is produce erythropoietin. So if you have somebody who has damaged or impaired kidneys, they're not going to produce as much erythropoietin. That can cause a problem. You need iron that's stored in your body as ferritin. You need vitamin B12 from your diet. And you need protein, folic acid, and vitamin B6. All those things need to be present for red blood cell development. Okay? So as we start looking at the different anemias, you may see some that are going to relate right back to those requirements. We don't have the requirements to be able to make these good red blood cells. So, as I mentioned before, anemia is an abnormally low amount of circulating red cells, hemoglobin concentration, or both. Okay? Very important that you understand anemia is a sign of an underlying disorder. It is not a disease in and of itself. There is an underlying disorder that's causing the anemia. So, three major types of anemia, okay? Hypoproliferative, so here there is a defect in the production of red blood cells. The problem is with the production. You have hemolytic, which is where there is excessive destruction of red blood cells. Remember, they're supposed to live 120 days, and here you have either early or excessive destruction of the red blood cells. And then, of course, you have just loss of blood, bleeding. I just am losing those red blood cells. All right, so looking at health promotion, kind of understanding how red blood cells are produced, it makes sense that having an iron-rich diet is going to help. Things that are fortified with iron, foods that are, iron fortified. Also fish, poultry, dried peas, beans. You want to try to avoid organ and red meats. Although they have a lot of iron in them, they also have a lot of fat in them, and they also have a lot of purine in them, so they're recommended to be avoided. We also look at supplementation with iron and folic acid, particularly for women, because the research out there supports that lack of iron and especially lack of folic acid are risk factors for a developing fetus to have things like spinal bifida or spinal issues. Additional risk factors for anemia: age, middle and older adult, just because our bodies just simply aren't producing red blood cells the way they were before. Of course, acute or chronic blood loss, so menstruating females, GI bleed, surgery. Situations that cause increased hemolysis, such as sickle cell disease, autoimmune diseases, any type of external trauma, a fall, motor vehicle accident, internal trauma, okay, if you have a mechanical heart valve that actually causes trauma to the red blood cells. Inadequate dietary intake if your patient has a vitamin B12 deficiency. We'll talk a little bit more about this in Unit 4, but if your patient has stomach problems, if they've had a partial or complete gastrectomy, gastric bypass, their stomach is not producing intrinsic factor, which is needed for vitamin B12 to be absorbed. Okay. Inadequate intake pica, which is just defined as ingestion of non-nutritive items. And it can be anything from dirt to hair. There was some weird show on TLC. It was this woman who used to eat her own hair. To also ice. Okay, and the whole idea is if they're eating these things, they're not eating other things that have the nutrients that they need, so then they're going to be malnourished. And other risk factors would be bone marrow suppression. So that can be things such as immune suppressants, chemotherapy treatments, that sort of thing. So what are you going to see in your patient? Mild cases of anemia are likely going to be asymptomatic. But the first thing you want to look at is their overall generalized color. If they appear pale, that's a pretty good sign that they might have some anemia going on. They're likely going to be fatigued and irritable, and this is just simply because, when they're anemic, they don't have as many red blood cells that are supporting the oxygen going to all the cells. They might experience some numbness and tingling of the extremities. This, again, is because of, lack of oxygen to those cells. Again, it can indicate a long-term anemia as well. Dyspnea on exertion, again, because with activity, their body just doesn't have the capacity to keep up. Sensitivity to cold. And if the underlying cause is sickle cell disease, they may have pain and hypoxia with that as well. Objectively, they might be short of air at rest. They might be short of air with exertion, especially on exertion, and also fatigued. If you're thinking about a nursing diagnosis for this patient, activity intolerance is probably the top one. Tachycardia and palpitations, especially with activity, that'll go up even more with activity. Dizziness or fainting upon standing or with exertion. I mentioned before about the pallor, but you can also look at the nail beds, and those will be pale. Their mucous membranes will be pale. If the anemia is related to a B12 deficiency, look at their tongue. It will tend to be very smooth, it will be sore, and it will be bright red. You may also see some ulcerations at the corners of the mouth. Okay. So looking at anemia from an assessment perspective, you want to evaluate their nutrition. What is their typical intake? You can do a 24-hour recall. You can ask them to have a food diary, kind of describe what their typical intake is. From a cardiovascular perspective, you want to focus on central cardiac, listening to heart sounds. You also want to assess peripheral pulses. You want to assess capillary refill, temperature, color of the extremities. Understanding that a low hemoglobin is going to cause the heart to pump harder and faster because there's not as much oxygen carrying capacity. So the heart is going to beat harder and faster in an effort to deliver oxygen to the tissues. Now, the problem with that is the heart can only do that for so long. and that increased workload, especially over a period of time, can lead to heart failure. From a GI perspective, we usually think about GI as the potential source of loss of blood. So you want to pay attention when they're brushing their teeth if they have any bleeding gums. If they vomited, is there any visible blood in there, or is it coffee ground emesis? When blood hits hydrochloric acid, it kind of gets brown and looks like coffee grounds. So if it's coming from the stomach, if the bleeding source is the stomach, when they vomit and they have coffee ground emesis, it means they have a stomach bleed, a gastritis, something like that. Melena refers to blood in the stool. Again, it could be gross blood where you can visibly see it, or it might be microscopic and the stool might look black and tarry. Neurologically, you want to assess for numbness and paresthesias, ataxia, which is difficulty walking, poor coordination, even up to confusion and delirium. This is typically seen with your long-term anemias, particularly related to like your vitamin B12 and your folic acid and that sort of thing. So just to briefly go over the RBC indices, realistically, as a staff nurse, you're not really going to be looking at these items in a CBC. I just want you to be familiar with them. Basically, what this does is the RBC indices help the provider determine what type of anemia the patient has. Okay, that's really all it is. So for us in our role as a staff nurse, it's not something that's really going to impact us. Once the cause is identified, we can treat the underlying cause and then continue with our typical anemia interventions. Okay, so MCV looks at the size of the red blood cell. MCH looks at the amount of hemoglobin per red blood cell. MCHC looks at the amount of hemoglobin relative to cell size. And you can see there's some differences that you'll see there with iron deficiency anemia versus like vitamin B12. Again, not something that you're typically going to be dealing with as a staff RN. Additional lab studies you might look at, total iron binding capacity. This is an indirect measurement of serum transferrin, which is looking at the ability for us to bind iron in the body. Serum ferritin is an indicator of the total iron stores in the body. We can do serum iron. The Schilling test is going to look specifically at vitamin B12 absorption to tell us if the problem is that lack of intrinsic factor. We can do vitamin B12 levels, folate levels. Again, those are both substances needed for red blood cell production. So if those are reduced, okay, right there's the problem. We can be able to treat it, based on the underlying cause. And then, of course, the bone marrow aspiration, as we noted before. So medical management, and it's important that you understand that the initial treatment is going to depend on the patient condition. And there's a couple things that go into that. First of all is the severity. A hemoglobin, a patient with a hemoglobin of 9 versus a patient with a hemoglobin of 6. Obviously, the 6 is much lower. We have less oxygen carrying capability. They're going to be much more compromised than the person at the 9. The other thing that plays into this is an acute versus chronic onset. So let's say I'm at an 8 for my hemoglobin, but 2 hours ago I was at a 12. So I went from a 12 to 8 very, very quickly. I'm going to have much more pronounced symptoms. I'm going to be requiring a lot more support and care than somebody who 5 years ago they were at 12, and maybe over the past 5 years they've slowly drifted down to 8. Okay, when you have a slow transition like that, your body has time to be able to adapt. Okay, it happens more slowly versus a very acute drop. There isn't time for your body to adapt. So just kind of keep that in mind. Obviously, we need to correct or control the cause. I mean, we can do other things, and we can initially give them oxygen and transfuse them and do all that. But if we don't correct or control the cause of the problem, we're not really going to get anywhere. We're putting a band-aid on a hemorrhage, so to speak. Okay, so we have to correct or control the cause. From there, treatment is going to be specific to the anemia type. We're going to use things such as diet therapy, particularly if the problem is low iron or low, B12 or low folic acid, vitamin B6. We can do some diet and supplementation. In severe cases where your patient is extremely low or their cardiorespiratory status is compromised, we may need to transfuse them. We may need to give them blood products. Okay? Depending on what the situation is, in some cases you can have autoimmune diseases that actually destroy the red blood cells. If that's the case, we would use immunosuppressive therapy to kind of chill out the immune system. Regardless of the type, we are always going to use energy conservation, and we're always going to look at mitigating fall and safety risk. Okay? So energy conservation just simply means that we are going to allow for frequent rest periods for the patient. We're not going to have them do too much too quickly and too much at a time. Okay, they need frequent rest periods just simply because activity makes them short of breath, it completely exhausts them, fatigues them, their body just cannot keep up with the demand. Okay. Now, in relation to the fall and the safety risk, again, the patient does not have enough oxygen carrying capacity, so they are much higher risk for passing out, falling, being confused. So just thinking about some basic safety things. Now let's look at some very specific anemia types. So hypoproliferative iron deficiency anemia. So most common causes here are going to be blood loss, okay? And typically if we're losing blood, it's going to be either through the GI tract, or in menstruating females, it's going to be GU, okay? But the most common deficiency is going to be inadequate iron intake. This is typically a dietary issue, which is then compounded if somebody is actively losing blood through their GI tract or through menstruation. So labs and diagnostics, they'll do some blood work, they'll take a look at their ferritin so they can see what their iron stores are. Again, if that's low, that can indicate that they don't have enough iron. They'll look at the CBC with the RBC indices. They may do a fecal occult blood test, which is where they'll take a sample of the stool and look for hidden blood. Or they may do a CT scan or some sort of endoscopy or scope procedure if they believe the patient is actively bleeding. What we do for these patients, they need to increase their dietary intake of iron as well as vitamin C. Vitamin C is going to enhance the absorption of iron. So foods that are rich in iron include organ meats, just meat in general, beans, particularly black and pinto, green leafy vegetables, raisins, and molasses. Okay. Vitamin C, obviously you're looking at your orangey type foods. We may need to do some supplementation with iron, okay? Iron supplements can be given PO, there's IM preparations, there's also IV preparations. We will talk more about these in class. The hemoglobin itself may increase in a few weeks, but actual iron stores in your body take about 6 to 12 months to replenish. So again, when you're thinking about this, we're going to do this for your patient, but if they're having an active blood loss, that they have a GI bleed, we don't have the time to just treat them with increasing their iron and vitamin C. Okay? They're going to need some transfusion, that sort of thing. Now, your megaloblastic anemias, this is your folic acid deficiency and your pernicious anemia, the lack of vitamin B12. These are things that these are the other types of anemias you're going to see. So folic acid deficiency, We see it in pregnancy just because your body's using more because you have the developing baby. But a lot of times it's related to malabsorption, and we see it a lot in patients who are alcoholics or drink a lot simply because they're consuming alcohol instead of good nutrient foods. Pernicious anemia is specifically a vitamin B12 deficiency, and it can either be because you're not consuming enough vitamin B12 or you're consuming it, but the stomach is not producing intrinsic factor, so it can't be absorbed. Okay? So it's really important to differentiate what exactly is going on here. So again, lab and diagnostics, they'll do the red blood cells, they'll look at the indices, they'll look at the peripheral smear to figure out exactly what's going on. So for folic acid anemia, again, dietary folic acid has to be converted to an active form, and vitamin B12 is needed for this to occur. So again, if your patient does not have intrinsic factor in the stomach, okay, this is going to be a problem because they're not going to be able to use vitamin B12 appropriately. So the folic acid actually gets absorbed in the duodenum. You do excrete quite a bit daily. The current recommendation daily is 400 micrograms for adults and up to 600 or higher for women of childbearing age. And the idea is obviously taking it during pregnancy, but they're encouraging it for any women of childbearing age because it's going to be a little bit when you get pregnant until you realize that you're pregnant. And by then the spinal cord and everything has already formed. So the idea is to be proactive. So dietary sources of folic acid, really it's in all types of foods, but it's higher amounts in green leafy raw vegetables, your liver, your peas, lentils, oranges, asparagus, beets and broccoli. And they now actually have products that are specifically fortified with folic acid as you're looking at the labels. We can supplement this. Folic acid can be given PO. It can also be given parenterally. For vitamin B12 deficiency anemia, again, the absorption of the vitamin B12 requires that intrinsic factor. So this intrinsic factor is secreted in the stomach. It's absorbed in the ileum. So if you have a patient who has stomach disease, whether it's gastritis, whether it's ulcers, maybe they've had a gastric tumor, they've had part of their stomach removed, or they've had part of it bypassed, as in gastric bypass weight loss surgery, they are going to have a lack of intrinsic factor. Also, patients that have ileal disease, so the problem is in the ileum, are going to have problems absorbing B12. So your chronic bowel diseases, irritable bowel syndrome, inflammatory bowel disease, Crohn's, that sort of thing. And also those that are strict vegetarians that don't have any meat and dairy, and that's just simply because they're not taking in enough vitamin B12. The problem with vitamin B12, particularly long term, is it will result in neurological damage. So they will have numbness and tingling in their extremities. They will have problems with their deep tendon reflexes. When you go to the doctor and they use the little reflex hammer checking you out. They'll have issues with memory loss. Severe cases, they can have issues with psychosis. You'll see that I made bold and red, the beefy, sore, red, smooth tongue. Okay? Very, very classic to vitamin B12 deficiency. Okay? So the daily requirement, 2.4 milligrams, it should say per day for adults. Dietary sources are going to be your animal products. Of course, liver and dairy are your biggest ones, and also fortified foods. Supplemental wise, we can give PO preparations. Those are fine for patients that do not have lack of intrinsic factor or do not have absorption issues. Okay, POs would be great for your vegetarians. If they have no intrinsic factor, they definitely need the intranasal or the parenteral. And I would even say if they have ileal disease, you're probably looking at intranasal or parenteral just simply because of being able to absorb it. So you heard me mention before about the Schilling test. And this is very definitive that can determine your body's ability to absorb vitamin B12. So this is really good to determine if the problem is intrinsic factor or not. So basically the patient is given a PO dose of B12 that has a radioactive tag on it, okay? And they monitor the patient's urine then. They're going to get a urine sample and then test the urine to see if the radiation is there. So if there's no radiation in the urine, well, then that pill essentially passed through the GI tract and none of it was absorbed, okay? Because for it to get to the kidney, that B12 must have been absorbed out of the GI tract. So if it is detected in the urine, the problem is not ileal disease or a lack of intrinsic factor. So it just kind of helps determine what the underlying cause is. With your megaloblastic anemias, again, how we treat them, we need dietary intake of folic acid, dietary intake of vitamin B12. Supplemental replacement, typically for B12 in particular, it's going to be lifelong. Again, you can do a PO, parenteral. B12 can also be given intranasally. From an assessment perspective, you want to watch their skin to see are they showing any issues with jaundice, vitiligo, which is decreased areas of pigmentation on the skin, and premature graying of the hair. Those are all associated with these types of anemias. The tongue, you heard me mention that before, that bright red, beefy, sore tongue. Once we start treating them with the supplementation, that should resolve in a few days, okay? However, in the meantime, that tongue is very sore. So small, bland meals are going to be very important. Now, the neurological signs and symptoms can take weeks to resolve. And sometimes, depending on how long it's been going on, you may have some permanent damage as well. So you think about assistive devices for safe ambulation, PT and OT. Because they have that diminished sensation, we worry about heat and cold injury, particularly to the extremities, because they may not have the sensation that something is too hot or too cold, or that something is hurting them. Very similar to like a diabetic. You can also have anemia associated with renal disease. You heard me mention that before with the erythropoietin. It's a hormone produced in the kidneys. If the kidneys aren't functioning properly, I don't have enough erythropoietin, so I'm going to have fewer red blood cells, and they're not going to live as long. The other thing, oh, there's a typo there. It should say iron and folic acid lost during dialysis treatments. So as these patients with end-stage renal disease are receiving dialysis and they filter the blood and return it to the body, they're also filtering out the iron and the folic acid, which then further contributes to the anemia. So this is typically treated with epoetin alpha, commonly known as Procrit or Epigen, that will stimulate the production of red blood cells in the bone marrow. So we're going to switch gears and talk specifically about blood products and blood transfusions. As a student nurse, you are not permitted to actively administer the blood product. You can observe the process, you can help with the monitoring of the patient, the vital signs in that, but you cannot be the one responsible for the blood product. And that relates to the scope of practice and also facility policies. So that being said, as a new grad, you're going to be expected to know this stuff. So it's really something, if you have the opportunity to observe on the unit, you definitely want to take advantage of that opportunity. So looking at blood products, we can infuse whole blood, which simply has all of the components in it. We can do packed red blood cells. We can do washed red blood cells. We can do white blood cells. We can do fresh frozen plasma, which is also known as FFP. Albumin, we can do clotting factors, we can do cryoprecipitate or platelets. These are all considered blood products. For the different types of transfusion, we have pretty much our standard transfusion, which is where a patient is receiving blood from a compatible donor. Or you have autologous, where the patient is being transfused their own blood. Now, this blood could have been banked. Like, for example, the patient knew they were going in for surgery the following month, so they went ahead and donated some of their own blood that they could receive back. Or it could be intraoperative blood salvage. So in certain cases in the OR and traumas, you might hear the term cell saver. These are things where we can use these devices to trap some of their own blood, and depending on the circumstances, we might be able to transfuse it back to them. So it's important to understand the transfusion protocol. Patients need to be typed and cross-matched, okay? So what that basically means is they need to make sure, or we need to make sure, they are receiving the correct type of blood, both the type and the RH factor. So that's the typing. So we draw some blood for them to figure out what their type is. And cross-matching is taking a small portion of the patient's blood and a small portion of the donor blood and mixing them together in a petri dish to see if they have any type of bad reaction. That's what we call cross-match. As a nurse, it's very important for you to assess the patient and ask them if they've had any previous transfusion reactions. If they've had a previous reaction, they're at higher risk to have a reaction this time around. You want to review the labs, particularly the H&H, to see where they're at. Okay? We'll actually be trending H&Hs to see how the transfusion helped them. There is a special consent form to receive blood products, different than just the basic hospital consent. As a nurse who's giving this, we need to verify the prescription. What specific product are they receiving and what is the amount? A lot of times we'll be giving packed red blood cells. Are you giving 1 unit or 2 units? Okay, that's important to know. Your patient needs to have appropriate large bore IV access, and they really need to have 2 separate IV sites. Ideally, it should be an 18 gauge. Most hospitals will let you get away with a 20, but you take the risk of the size of the IV damaging the red blood cells that we are infusing into the patient. So 18 gauge is where you want to go. For the blood tubing, it's an actual special type of tubing they use for a blood transfusion. It's considered a wide tubing, and it has a filter. That needs to be primed with 0.9% sodium chloride, and you can hook that up to the patient so the sodium chloride is running KVO. You can only use normal saline with blood tubing. You'll get the blood product from the blood bank. There's a process they go through down there to make sure they are giving you the correct product. You want to inspect that product for discoloration, cloudiness, excessive bubbles. When you get up on the unit, 2 nurses, at least one of them need to be an RN, need to verify the product, okay? And not just is it the correct thing, but there's special issue numbers on there, the expiration date, the patient number. It is really an involved special protocol that they go through, just because this is considered a high-risk procedure. You want to assess vital signs and temperature before you start the transfusion, and you have to start that transfusion within 30 minutes of getting the blood product from the blood bank. Okay, so timing is extremely important here. Once you start that transfusion, the RN has to stay with the client for the first 15 to 30 minutes of the transfusion. Okay, physically with the client. So when you have an RN who's taking care of a patient who's going to be receiving blood products, he or she is going to be spending a lot of time in that room. So you need to kind of consider that with the rest of their patients, okay? Because they have to stay in the room for the first 15 to 30 minutes of that transfusion. Because the reality is, if they're going to have a severe life-threatening reaction, it's typically going to happen within that time. So in that first 15 minutes, that they start the blood product, we're going to go slow. Okay, 5 milliliters per minute for the first 15 minutes to see how they do. Okay, we're going to continue monitoring their vital signs and temperature. 15 minutes, 30 minutes, 60 minutes, and then hourly. If after the first 15 minutes everything is still stable with the vital signs, the temperature, the patient, they're not short of breath, they're not itchy, they're not having pain, then we can increase the rate of the transfusion. You want to get it in over 2 to about 3.5 hours. It cannot extend past the 4-hour mark after you've started the transfusion. Okay, that is very important. You also want to monitor very closely for fluid overload, because typically if we're giving a unit of packed red cells, you're talking about 200 to 250 milliliters, and we're putting it in them fairly quickly. So we worry about them getting too much fluid too fast and going into fluid overload. Older adults are going to be at highest risk for this, so you want to closely monitor their respiratory status, their breath sounds. If they start developing crackles in the bases, I'm starting to think about fluid overload. Noting any neck vein distension, that maybe they're retaining fluid, and if they have sudden anxiety, often coupled with shortness of breath. That's a big red flag. So I put this up here. There's lots of different transfusion reactions that can occur. And these are the 3 big ones and the 3 that you may be most likely to see. You can have an allergic reaction that can be mild to severe. Mild, you'll just see some facial flushing, some hives and rash. Severe will go all the way up to airway closure and circulatory collapse, so essentially anaphylactic shock. You can have a febrile reaction where their temp starts going up, they get chills, anxiety, tachycardia, tachypnea, or you can have a hemolytic reaction. This is where the body is literally attacking the red blood cells and it's destroying the red blood cells. So low back pain, chest pain, fever, tachycardia. With any type of transfusion reaction, your first thing that you want to do is stop the blood. Okay, stop the blood, stop the infusion, and then you want to infuse normal saline. But you want to do it with separate IV tubing, because just think about this for a minute. The blood is still down in the tubing, okay? So if I would shut the blood off and just run the saline through the same blood tubing, I still have blood in the tubing that would go into the patient. I don't want that to happen. So I have to have new tubing to be able to infuse that normal saline to support the IV access and to support circulatory function. So again, transfusion reactions, stop. Stop the transfusion, stop. You want to start normal saline with a separate line, save your blood bag and the remaining blood and tubing, because that will need to be returned to the lab. Okay? You also need to assess the patient. Obviously support the patient. If their blood pressure is down, we have to infuse fluids. If they're not breathing, we have to support them with ventilation. Notify the provider. If they have an issue with fluid overload, we want to obviously notify the provider, give oxygen, monitor their vital signs. We may need to slow the infusion rate, but again, you have to be finished with the infusion for that unit within 4 hours from your start time. So many times, if that's the case, the provider will often prescribe an IV diuretic. Typically, it's going to be IV furosemide Lasix. The other complication we look for is sepsis or septic shock. So you might see fever, chills, nausea, vomiting, abdominal pain, hypotension. Again, we're going to stop the reaction. Our focus is stop the transfusion. Our focus is maintaining airway patency, supporting oxygenation and ventilation, IV fluids, vasopressors, and then we'll do cultures and antibiotics. Basically, we're treating them for a shock condition. Post-transfusion, again, I'm going to mention you really want to complete the transfusion within 2 to 4 hours to avoid bacterial growth in the blood. 4 hours is the maximum cutoff. You need to know that. Post-transfusion, you want to get a final set of vital signs, and then they will typically be vitals every 4 hours or per protocol. Usually it's every 4 hours for at least the first 24 hours. The bag and the tubing set gets disposed. It's per protocol, so that goes into a biohazard bag. Some facilities actually have everything returned to the blood bank, whether it's had a reaction or not. So you would need to know your facility policy. You want to monitor the lab values. Your hemoglobin level should rise approximately 1 gram per deciliter with each unit of packed red cells, and you want to document your client's response.